Malaria case management training for healthy professionals. Malaria in special groups. Learning objectives. Describe the relationship between malaria and pregnancy and lactation. List measures to prevent malaria during pregnancy. State the recommended therapeutic regimens for the treatment of uncomplicated and severe malaria during pregnancy and lactation. Describe the prevention of malaria during pregnancy. Describe the effect of malnutrition on malaria. Describe the effect of HIV on malaria. Describe the effect of TB on malaria. 1. Malaria in pregnancy. The symptoms and the complication of malaria in pregnancy vary according to transmission intensity and the level of acquired immunity. Pregnant women are living in areas of unstable malaria transmission, have little or no immunity to malaria, and are at higher risk of developing severe malaria than are non-pregnant adults living in the same area. Effects in unstable areas. In these areas, malaria is a major cause of maternal anemia, spontaneous abortion, stillbirth, premature delivery, low birth weight or birth weight less than 2.5 kilogram, neonatal disease and maternal disease. Severe malaria symptoms: hypoglycemia, cerebral malaria, and pulmonary edema are the more common in pregnancy. Effects in stable areas. Pregnant women living in stable transmission settings. The deleterious impact of malaria is particularly apparent in first and the second pregnancies. Partial clinical immunity acquired prior to pregnancy does not prevent infection, but does reduce the risk of severe disease. Clinical malaria is not a prominent feature of infection during pregnancy. The major detrimental effects of infection are low birth weight, LBW, and maternal anemia. Treatment of malaria in pregnancy. Pregnant women with acute malaria are a high-risk group and require effective anti-malarial medication. Uncomplicated malaria treatment. In all trimesters of pregnancy for Plasmodium falciparum or PF or mixed infection, AL or Cortam is recommended as routine treatment. Uncomplicated malaria treatment. Continue. For the treatment of Plasmodium vivax malaria in any trimester of pregnancy, give chloroquine, which is safe in pregnancy. Primaquine is contraindicated during pregnancy. The treatment of malaria in lactating mother is the same as the non-pregnant adults, except primaquine should be avoided. Treatment of severe malaria in pregnancy. A pregnant woman with severe malaria should be given a parenteral antimalarial medicine in full doses without delay. Parenteral artesunate is more effective than parenteral quinine in reducing the risk of this from severe malaria. Treatment of severe malaria. Artesunate IV or IM is the preferred drug for all severe forms of malaria in all trimesters of pregnancy. Intramuscular or IM artemether is the second option. After 24 hours, full dose of AL or Cortam in all trimesters. Pregnant women should be given priority in long-lasting insect net utilization. Intermittent preventive treatment of malaria during pregnancy. IPTP is recommended in high transmission areas. IPTP is not recommended in Ethiopia. Second, malaria and malnutrition. Malaria and malnutrition frequently coexist. Malnutrition may result in inaccurate dosing of if we use age or weight of the child. Different conditions may hamper the absorption of anti-malarial drugs. These are chronic or persistent diarrhea, vomiting, rapid gut transit, or atrophy of the small intestine, villi, or enteropathy, diminished muscle mass may also make repeated intramuscular injection difficult. Hypoalbuminemia. Hypoalbuminemia may also lead rapid clearance of the drugs, as some drugs need albumin for binding, but there is no dose modification of any antimalarial drugs. However, the response to treatment should be monitored more closely. 3. Malaria and HIV. There is a geographical overlap between malaria and HIV, and many people are co-infected. Worsening HIV-related immunodeficiency may lead to manifestation of severe malaria. In areas of stable malaria transmission, patients have more frequent and higher density infection due to partial immunity. In unstable transmission area, HIV infection is associated with increased risk for severe malaria and malaria-related disease. Early studies suggested that HIV-related immunosuppression was associated with decreased response to anti-malarial drugs, but there is insufficient information to change the drugs and the dose of anti-malarial drugs we use for non-HIV infected individuals. 4. Malaria and TB. Rifampicin with quinine. ACTC and mefloquine have a 3 to 9-fold increase of the anti-malarial drugs in the serum, as well as higher recrudescence rate. However, there is insufficient evidence to change the drug and dosing in patients who are taking anti-TB drugs, but these patients are at high risk of recrudescent infection They should be monitored closely. Thank you.